Minute one, what to ask. It's so easy. The big idea here is, have they ever had a complication before in their foot? If it's been a wound, if they have a diabetic foot ulcer history, you can almost stop the exam there because you know that they're already in the highest risk category. But that is the most important thing. If they've ever had a history of an ulcer, or obviously any lower extremity amputation, a toe amputation or higher. If we do, then you know that they already have neuropathy and or possibly peripheral artery disease, and that automatically bumps them up in risk. You also can ask about history of diabetes, heart attack, stroke, all the other cardiovascular complications, as well as hyperlipidemia, high blood sugar, and high cholesterol. Then after that minute, what to look for. And this is a rapid, evidence-based exam. Is there any discolored, ingrown, or elongated nails? Are there any signs of a fungal infection? Are there any obviously open wounds? Just separate the toes. There's often some maceration in between the toes, and sometimes even a wound in between the toes. And then the neurologic exam for assessing sensation, you can do a touch test. It's called the Ipswich touch test. It just takes a couple seconds. Then the musculoskeletal exam. This is really easy. All you have to know is there a rigid deformity that doesn't reduce when you try to reduce it? And do they have full range of motion of the joints? And you can look for any calluses. The callus in a foot with diabetes is the equivalent to a breast lump in cancer. That's the big idea. And then on the vascular exam, just take your hands and feel for those postals. Feel for the dorsalis pedis on the top, feel for the posterior tibial back around the ankle. And if you don't feel it, then that might be worth you going to get a non-invasive vascular study or ordering that or ordering a Doppler exam. But if you can't feel it, don't worry about it. Just kick it over to the foot doctor and she or he will help as well. You also can look real quick as if there's a difference between temperature dramatically between the calves and the feet as well. Something really significant might cause you to be concerned about peripheral artery disease as well. So that's what to look for. Then we only have our third minute left, which is really quick. It's just what to teach. The big idea for this is just tell them to knock their socks off. Check their feet every day, just like they comb their hair or they brush their teeth. The risk for them goes down dramatically because if they see a problem, they're going to call you and they're going to call their foot doctor. And they may say, well, what do I look for? And you would tell them, well, listen, if you're looking at your feet every day, you're going to know because it's going to be different than yesterday. But the big idea is any redness that wasn't there the day before, an ingrown nail that's unusual, obviously any wound or any bleeding into a sock, but this 3 minutes, what to ask, what to look for, and what to teach are the most important 3 minutes for the life of our patient's limb.